All right. So on today's episode, we have Dr. Matt Beuter. How did you get started in a medical leadership role?
5 years ago, had an opportunity to move a little more into medical administration.
What kind of qualifications did you need?
The first thing you need is experience as a physician. Should they go back and get an MBA?
Whoa. There are all these MBAs already here. How many of you have an MD?
Your wife does the same job that you do. I just know from experience she does it better than you
do. Cheap shot on my own show. Interesting. Well, I guess that's all for Matt Beuter. Welcome to the InterestingMD podcast, the show about what doctors do when we aren't seeing patients and how this can help us find balance and prevent burnout. I'm your host, Rob Beck. All right, so on today's episode, we have Dr. Matt Beuter. So Matt is going to be here and talking about getting into medical administration. I'm going to let him give you his background, and we're going to talk more about that. But not only is Matt a chief medical officer, he is a cherished former colleague of mine. He was a mentor when I first started out in practice and remains to this day a very dear friend and a huge fan of Matt and his family. So Matt, thank you so much for coming on to the show.
Oh, you're welcome. Thank you, Rob. I appreciate those kind words. I'm happy to be here and look forward to the conversation.
Yep. All right. So Matt, tell me just for everybody, where are you, kind of what's your background in medicine and where things are just as a snapshot about where you are today.
Sure. So as you mentioned, I'm an internal medicine doctor. This year marks my 29th year in practice, 32 years since graduating med school. So I've seen a few patients come over the years. And as we talk today, I'm still doing my traditional internal medicine practice. It's at the Frist Clinic in Nashville, Tennessee, where as you mentioned, we practiced together for a number of years. I've spent all 29 years of my career at the Frist Clinic. I do traditional internal medicine, so I see patients in the office, and I also care for my patients in the hospital when they're hospitalized, which I really enjoy, being able to see patients across the continuum of care. About 5 years ago, had an opportunity to move a little more into medical administration, which I know we'll talk more about later. But the bulk of my career has been spent as a traditional internal medicine primary care doctor.
Fantastic. So where did you grow up?
Well, I was born in the Midwest. Born in Iowa, was raised to 6th grade there and then moved to Indiana. Went to college in the Midwest and then worked my way south to eventually settle in Nashville, Tennessee.
Okay, so did you go to college at Notre Dame?
I did.
Okay,
yes,
all right. We just need to get this out of the way. This is recorded a few weeks after the national championship game. I'm sorry. Thank you for coming on. As a Tennessee grad, Ohio State did worse things to us than they did to you. So
fair enough. I'm not wearing black anymore, Rob. It's okay. My Puritan mourning has ended. And I'm looking on the bright side that we made it to the national championship. And I think we have a good foundation laid to hopefully return there in the future.
Yeah, absolutely. I mean, thanks to the transfer portal, you may be able to replace your entire team with the Ohio State team. So
I don't think we're going to need to do that. I mean, since we're digressing on to college football, our coach said we might minor in the portal, but we will never major in the portal.
So interesting.
Yes, we like our culture as it is, and we'll bring in players that fit our culture.
Interesting. Okay. All right. Well, best of luck to you. I think that Tennessee's going to sell out as much as we can. So
it's a changing landscape in college football, just like it's a changing landscape in healthcare. Maybe not as drastically as it has been for them, but one of the things I'm fond of saying, Rob, is the only thing that never changes is change.
Very well said. And, I think that that's something I really want to talk about on this podcast is things oftentimes change very quickly around us. Things don't go well for us sometimes, or that there are a lot of aggravations and there are a lot of things that really bother us, that weigh us down, that cause burnout, huge topic in medicine these days and in healthcare. And so I want to be able to talk about ways that we have people that are fighting against that. And that's what this is all about.
Great.
So Anyway, all right. So you're still practicing. How does that work with being a chief medical officer? What are your hours for each?
Well, I spend, if you try to divide the week up into a 5-day work week, I spend half my time in clinic and half my time doing administrative tasks. So really, I wind up seeing patients 5 half days in the
Okay.
office. I have
Okay.
1 full day in the office, 1 full day of administrative work, and then 3 half days. Of course, it's not all quite that set in stone. There's a lot of fluidity to the schedule. Sometimes I move things around. But generally, I split my time. And when I started this, it was actually my wife, who I get a lot of wise advice from, that told me, a half-time job and a half-time job is a job and a half.
Right.
So sometimes some weeks are busier than others, but generally I try to split it 50-50, adding up to 150.
Nice. Okay. Well, and how are you finding that balance, being able to do this right now?
Right. Well, again, it depends on the week. I mean, some weeks are busier. Sometimes I have a week where I have several patients in the hospital and get an admission, and things are heavier on the clinical side. And then sometimes I have weeks where there's some, red alarm fire that occurs on the administrative side, and have to do something related to that. So it's only really a challenge for me when both of those areas are hot at the same time,
Right. Fair enough.
which doesn't
Okay.
happen often, thankfully.
Good. Wonderful. All right. So for this job, there are lots of different CMO uh, jobs out there and positions out there. So yours is with a major healthcare system. And are you inpatient, outpatient, both?
So on the CMO side, I'm essentially exclusively outpatient.
Okay.
Other than the fact that some of my doctors do inpatient work, and so I overlap a little there. One of the reasons I still like maintaining an inpatient presence myself is I see some of them there.
Right.
But you can, my CMO role is a little bit non-traditional in that when the CMO role first started coming about, it was primarily associated with a facility, right? So you were the CMO at a hospital. And my role is essentially more of an outpatient CMO role, where I am responsible for all of the employed physicians in my division of the large healthcare company that I work for.
Okay. And how many doctors is that roughly?
It's about 250 doctors and about 300 advanced practice providers, PAs or nurse practitioners.
Okay. Wow. It's grown.
Yes,
Wow.
yes, it
Uh,
has.
let's talk about a little on how you got started with all this. I assume that this did not start out by them coming to you in clinic one day and then saying, Matt, come over here. How did you get started in a medical leadership role that kind of started you out on this pathway?
Yes. So I think everybody's path will be individual to themselves. But my particular path, and which I think is fairly common, started through the hospital committee structure. And that's definitely something I would advise an early career physician to consider is you want to get your experience here on a hospital committee. So when I first started out, I was on the Pharmacy and Therapeutics Committee, just as a member of the committee. And I got some insight into how the committee structure worked. Then I moved on and I became the Credentials Committee member. Then I was Credentials Committee chair, so I sat on the Medical Executive Committee. Most people say just the MEC. And so I worked my way up through various hospital committees with increasing responsibility. And that gave me some insight into how the CMO at the hospital worked, how the structure of medical administration worked through the medical staff office. And through that experience, I started to realize, there's value in this. I'm impacting other doctors' lives. It's very important for us as physicians to have a voice in various decisions that come before the hospital. And then after doing that, I was elected as the president of the Frist Clinic, where we mentioned we worked together earlier. So I did a 4-year term as Frist Clinic president, which eventually led me to the role I'm in today.
Okay. And so with the Frist Clinic, that's a large multi-specialty clinic that has a lot of moving parts, lots of general internist. Then it's also got GI, ID, endo, um,
Pulmonary,
pulmonary, I guess rheumatology as
rheumatology. Yeah,
well.
exactly.
Yeah,
So multi-specialty. There's
yeah,
about I think 37 physicians in our group now.
yeah. And a very, very high volume practice
Absolutely.
with very hospital based and very, very high volume practice. So,
Absolutely. When I
uh,
did that role, I still kept my practice as well. So it's different than being, I wasn't a full-time CMO of a multi-specialty practice where I was 100% administrative. In fact, I was still running my practice full-time and did the president's role on the side with significant support from the administrative side of our clinic and two other doctors that sat on the administrative council with me.
yeah. So under Wendy's math, that was 2.5 jobs, or was that
Yes.
two full jobs?
Yeah, well, I don't know how far we want to digress, but when I finished my term as first clinic president, Wendy, my wife, you mentioned, she said that is the last time you will do an administrative job until our youngest child leaves high school. And and so I went back to the general population, and then when the healthcare system I work for, came to me and said, "We think we want to make you the outpatient CMO," I said, "Well, I still have a 1 year countdown before I'm eligible for for something like that." And fortunately, after talking about it for a little while, they waited for me, and I didn't start until my youngest child had left high school.
All right. So how do you feel like all of that time, all of that effort, what were the things that you were doing? Because I think sometimes that junior members in practice or people who are on the outside, they kind of don't understand what's happening in the background on these committees, and whether it's the MEC, chair of medicine, group practice president, and that, yeah, I think some people wrongly think that you're conspiring against all the regular people and general population. But what are the things that you're doing so that people can kind of understand that and what they might be getting into?
Well, I think the most important thing when you're in a leadership role is transparency, and which generally then generates trust, right? You need to be transparent with decisions that are made so that your partners or the physicians that you're leading kind of understand why there was a decision to be made, and then what the rationale was for why you made the decision that you made in conjunction with the other people you work with. Rarely are these decisions made, so I don't work in a monarchy, right? I mean,
Right.
it's more of a democracy.
Yeah.
So it's shared decision making. But I
Yep.
think when you're early in your career, first it's important to use the skills that you worked so hard to gain, right? I mean, you worked a long hard road traveled to become a doctor and to learn how to take care of patients doing whatever specialty it is you do. And number one, you want some experience doing that. And number two, if you think you want to get into medical administration eventually, it's very valuable to have had a good chunk of time working as a physician, taking care of patients, so you understand what the doctors that you're leading are living with, are
Yeah.
experiencing day to day. The decisions that I was jointly making with my administrative peers when I was the president of our group certainly impacted more the flow of the workflow in the office. Um, in my current role as the division CMO, I have a much wider role, and the decisions that I participate in making have a much broader impact. So there's been sort of a stepwise process to get to the spot I'm at now,
Yeah.
and to influence more physicians. Which I think a story that I recall talking about this is when I was considering a CMO role, and another physician came to me and said, right now you're impacting your patients, which is valuable. I mean, we all
Hmm.
impact the patients we see. Um, but if you impact another doctor, then you're impacting all of their patients too. That attracted me a little bit, the idea that, gosh, if I impacted, 250 physicians to varying degrees at varying times, then I'm really impacting all of the patients they care for. And if you sometimes there are situations where you really help help a physician if they're burned out, they're thinking about stopping practice, or they're considering leaving practice, retiring early, whatever the case may be. If you can help that person regain some of the passion for patient care, then you have just made a significant impact on all their patients moving forward. I found that to be one of the things that really attracted me to doing some of the CMO work that I do.
In order to get this role, what kind of qualifications did you need?
I think I mentioned this earlier, but I think the first thing you need is experience as a physician. You really need to have worked for a significant number of years in whatever specialty that you've trained in as a foundational qualification to be a CMO. You'll sometimes, I've heard, residents in training say, geez, I want to finish my training and I want to do what you're doing. So, well, hold on. You need to get some experience first. So I would say your number one qualification is just that. You need to have worked as a doctor in your specialty for several years before you'd consider starting to shift your focus. After that, what you need is experience in administration. So what I said earlier, you kind of go back and look, you need some experience in how committees work, how to put together a decision-making group and lead them. It's valuable to have some experience in various leadership roles. One of the big questions that I think comes up for physicians is, should they go back and get an MBA? Do you need an MBA to be a CMO? And I'll tell you, I don't have an MBA. I don't think it's necessary. Now, that doesn't mean it might not be helpful, but that's different than being necessary. So you can get an MBA. It's another credential to add to your CV. But if you do CMO work for several years, you'll almost get a little mini MBA on the side. You wind up getting enough experience in these meetings, looking at various business plans and so forth, that if you pay attention, you'll get your own on-the-job MBA. And one of the things I always say is there are a fair number of MD MBAs, but rarely is there an MBA that goes back to med school.
Right.
Right. There's not too many MBA MDs. So I think it is reasonable to consider an MBA, time invested, probably tuition invested and so forth. But I wouldn't say it's necessary as a qualification to be a good CMO. If you're a CMO at a hospital, guess what? You're going to be working with the CFO and the CEO, both of whom are going to have more business experience than you'll ever have. And those people are on your team, so you can work with them.
Yeah, this is a subject that has bothered me for quite a while. I always look around and say, when you're in a boardroom there, or in the C-suite of the hospital, or in your practice, your multi-specialty group practice, whatever, and there's the business people on the side, and they tell you that if you want to become a CMO, you have to have an MBA so that you can speak our language. And it's like, whoa. There are all these MBAs already here. How many of you have an MD? Mm-hmm. It's your experience, it's your knowledge that they need. I know that there are some people that feel like that's, or some companies that feel like that's a box you have to check. Obviously HCA was not one of those. But it is listed on a lot of resumes, and it's a lot of job postings that an MBA is required. I don't know. It's not so much.
Look, Rob, I don't agree with that.
Yeah.
And if I'm not the one posting the job, now if it's an industry CMO job, maybe. But and as I said, it's not that it's not helpful. It might be helpful, but it shouldn't be necessary.
Yeah.
I don't think it's not a necessary qualification. You just said this, but I'm going to highlight it, which is oftentimes when I'm in these various meetings, I'm the only physician in the room. And I bring, I think, a perspective there that none of the rest of them have. That was one of the things that I found really gratifying when I started my CMO role, is to be, again, transparent and truthful, I really thought, oh, they're just going to have me here as the token physician. They already know what they're going to do, and they won't really solicit my opinion. And if they do, they may not pay much attention to it. Nothing can be further from the truth, right? When I started out, they'd ask me questions. I'd say, well, this is how the physicians will see this. This is how I think about this as a doctor. And they took that, and a lot of times it altered the course that we were going to take as a group, which is it's really satisfying to have people that are willing to listen, and also to know that you bring a perspective to some of these meetings that no one else has. Because as I said, they're not going back to med school and residency to get that perspective.
Definitely not. Definitely not. Well, I think that there are a lot of different places and different ways that you can take this. So if you do need to go out and get an MBA, or you want to go out and get an MBA, that's perfectly fine. There are just many different ways of doing that. There's the going back full time and taking 1.5 to 2 years to apply to business school and taking that time off of practice, and the tuition and the student loans that are going to come from all of that. Or there can be different programs like executive MBA programs, especially executive healthcare MBAs, that can be done on the weekends and at night, and maybe travel once a month. But even though I don't think that most people travel anymore for these types of programs anymore, but it's just something else that's going to add on to whatever your life burden is already, between a career, building a practice, maintaining a practice, whether or not you have a family, and any other things that you're going to do. But it's certainly something that's possible and seems to be pretty helpful in opening up doors.
Yes, you may find there are a few more doors open that otherwise may not have been open to you if you have an MBA. As I said a couple times, could be valuable, but not necessary in my estimation.
Yep, 100%. Okay. What have you noticed as far as, because I want the show to be a lot about burnout and prevention of burnout. Obviously, you're talking to a lot of physicians about burnout, and you're trying to help people through all of this. How has doing stuff, maybe with the exception of being a group practice president, made your practice better, made your life a little bit better, and helped you to prevent burnout? Because again, you're 29 years in and you're still going. So this is great. This is good for you. This is good for your patients. This is good for your partners.
Right. I mean, I think burnout is a challenging topic because so many of us are feeling that now. And everyone's situations are going to be a little different. So you have to really look at the individual doctor and say, what's at the root of this person's feeling like they're burned out? Is it, it's probably never going to be just one thing, right? But if they have a confluence of factors that have left them feeling burned out, where can you as a peer, or as this case, as the CMO, try and help this person rehabilitate their joy in medicine? So I think one of the first places we all look at when we talk about burnout is burden of documentation, administrative burden. Anytime you can reduce the administrative burden on a physician, I think that's going to lower the odds of them being burned out. We'd be missing the big topic if we didn't talk about the electronic health record, which hasn't, when I started practice, right? First, if my pager, which I carried when I started practice, went off, I had to go find the closest payphone. Like when I started practice, I've already aged myself with how many years I've been in practice, but I knew where all the payphone stations were in Nashville, Tennessee, that I could stop and answer my page. So I think that
so let me just stop you right there. For all the younger listeners, there used to be phones on the side of the road that you would have to stop and put quarters in, or dimes, or whatever it was at the time, that were available. And,
exactly. When I was young, it was a dime. When you were young, it was probably a quarter.
It was a quarter. Yeah, fair enough.
Yeah, it was a dime for me. But yes, I think, and then the electronic health record came along in the early 2000s, and we, we turned physicians into a lot in many physicians' view, more of a scribe, or more where you're just filling in documentation fields in an electronic health record. And that really is a risk for burnout, because the doctor is charting in their EHR at home at night. They're charting on the weekends. You don't feel any of the joy that you get from helping take care of another human being and get them better. So I think that is a big factor in burnout alleviation, which is to try to minimize electronic health record documentation, which, as we sit here January 2025, I think a big part of that is ambient listening technology. Maybe that's a topic for another podcast for you.
Yeah.
But the idea of how AI is bringing ambient listening into the exam room with the physicians, and how that allows the physician to connect better with the patient again and get some of the documentation done in the EHR accurately for them.
So are you seeing more and more of that? Because again, I moved out of the United States 4 years ago. I now practice in Canada. We're not using uh, that technology, at least where I am right now. But when I was at the Frisk Clinic, I had an in-person scribe. I had a physical scribe sitting in the room with me. And to be honest, I wasn't really sure that that was going to be all that helpful. But when we did transition over to electronic medical records in the office, we had young kids at that time. My wife has the exact same job as I do. And we did not have time to either take a 25% pay cut, or by seeing 25% less patients, or to work 50% harder. That was just, the math wasn't going to work with that. And so we actually ended up having in-person scribes. And to be honest, 98% of my patients loved it. They always thought that it was fantastic because I walked in, I sat down, and I just talked to the patients. And it was initially a little bit weird, but then actually patients got to know my scribes. They would talk to the scribes. They would, oh, have you gotten into med school yet? Have you gotten into your master's program yet? Oh, how's everything going? And that really, I probably ended up increasing the number of patients that I saw by about 10 to 15%. And that was a huge, huge benefit for me.
Yes.
And
Well, I mean, I knew that, of course, from when we worked together. I think that the era, I'll call it, of the in-person scribe is on its way out for sure, at least in the United States, because of the advent of what really everyone's calling ambient listening. There are multiple different companies that are in this space trying to compete for who's going to have the best product. But the idea that you can take usually it's a cell phone in the exam room with you, the cell phone through voice recognition takes a transcription of the conversation between you and the patient, or you and the patient and their family member who's with them, and can tease out individual voices and then build a medical progress note based on that conversation. This is AI as your scribe. Um, you don't have what you had, which is your patients getting to know your scribe, asking them if they get into med school. But what I would say is, well, if they did, then they left, and you had to train a new scribe.
right.
And what happens if that person's sick for a day, but you're still at work? Obviously, scribes have costs that go along with them, with benefits and everything goes along with employing a human being. Where having an AI powered ambient listening technology using a large language model to build your note, number one, no benefits to cost, never calls in sick. So, and also doesn't impact the patient's comfort level with the doctor. I mean, it's great to hear that your patients developed a good comfort level with your scribe being in the room, but from when you're still obviously seeing
Nobody
patients.
ever wants to talk about ED in front of a young woman
Yeah,
who's typing on a
yeah.
computer.
Or who wants to
That's
talk about the details of their depression or the fact that their spouse may be having an affair? I mean,
yeah,
there are things that we hear patients tell us as primary care doctors that they don't really want to talk about in front of a stranger.
Yeah.
So I know there's a lot of demands. I mean, you mentioned that your wife does the same job that you do. I just know from experience she does it better than you do.
And that is a verifiable fact. I just
Indeed.
100% verifiable fact that
I've got frontline experience to tell you. I'm confirming it. It is a verifiable fact. She's a better doctor than you are.
this may be the only way that I'll get her to listen to the podcast is to say, Matt Beuter said that you are the best Beck doctor there is.
Well, you just tell her that I told the truth, and then she can make of it what she wants.
It's a cheap shot on my own show. Interesting. Well, I guess that's all for Matt Beuter.
You did open the door, Rob.
but so for the people out there who are drowning, what are we're not going to talk about specific AI scribes and whatever else,
Sure.
but have you guys started using that yet? Have you started evaluating that yet? And
Oh yes, yeah. I mean, we're using it.
okay,
Yes, we are using it. I think it helps people who are feel like they're drowning in documentation burden. We're using it. It's gaining traction in the United States rapidly. And
interesting.
it's just one of the things that I think will help unburden physicians from things that are causing them to feel and be burned out.
Okay. So, what other things have you noticed that people are dealing with? And it doesn't just have to be family doctors, internal medicine, but some of the other employed doctors that you're dealing with. How are you helping them to deal with the burnout and other strategies that you've seen them use?
Yeah, I think, you know, finding joy in patient care again is a big deal. I sometimes talk to them about the science of compassion, which there's some good medical literature on this that says when you're compassionate, then you feel a real benefit from that. The old saying, "It's better to give than to receive." It's that's kind of what it's like. It's better to provide care to someone and help another human being. So I think that that's something I try and help physicians see again, which is we do good work here. There's joy in helping other people. Look at the good things you're doing for your patients, and I think that in some cases helps people reconnect to why they wanted to be a doctor in the first place, and what can bring them to work every day. I think sometimes doctors get too focused on seeing patients and they lose the ability to disconnect. So I talk to doctors about what their hobbies are. What do you do outside the office that you find enjoyable? And there's a wide range of things for that, right? Some people want to go hiking in the woods, which I encourage getting out in nature. Some people want to play on a hockey team. Some people want to escape into a book and read for pleasure. So whatever the case may be, I think it's important that as physicians, we maintain some kind of non-medical joy, some kind of non-medical connection that we can have that you find fulfillment in.
So, Matt Beuter just put out the entire trailer for the Interesting MD podcast because this is what it is all about, is finding other things to do that help you stay fulfilled, help you stay stimulated, and to just give you a little bit of a release from the daily burdens that you have that come along with healthcare in
Which is
North America.
critical. It's critical, right? That is one of the keys to preventing or alleviating burnout.
All right. And are you seeing success? Are you seeing less of the burden with going back to the AI scribes? Are you seeing people improving? I want people to see that there's hope out there and that there's some hope out on the horizon here.
Yeah, I am.
Okay.
I mean, the physicians that I have that are piloting the AI scribe that we're using are giving me feedback. It's given them time back. I even had one very interesting and telling conversation with one of the physicians. They were using the AI powered scribe. They used it for about a month, and then their spouse said, "Hey, is everything okay at work? And they said, well, yeah, everything's great. Why do you ask? Well, because you're not working at home at night anymore.
Wow.
And to me, that doesn't that say it all, right? The spouse notices that you're no longer um, spending an hour every night off with your laptop charting. So I want to emphasize that's one piece of the overall
Right.
thing, but it is one of the ones that's at the forefront right now because it's just coming to fruition for us after years of us working with the electronic health record. We may get to the point soon where the electronic health record works for us.
So, Matt, moving back to a CMO, when people want to think about different careers as a CMO and different positions, whether or not they want to do some more administrative jobs, what kind of salary can people think about, or how much money, honestly, can people make doing this? I'm not asking you to disclose yours because yours would be different, but how beneficial would this be for people to start pursuing in the future or getting into?
Sure. Well, I think there's, as you said, there's a range, right? It depends if you're going to be going into industry and be the CMO for a pharmaceutical company, or if you're going to be a CMO at a hospital. So as you said, there's a wide range. I think generally a CMO can expect to make a salary that's comparable to what you'd make if you were in practice. And that's the case because you know if you're going to attract doctors to do this, then they need to have some kind of comparable salary. Nobody's
Right.
going to say, I want to be a CMO and I'm taking a 50% pay cut. And if you made 50% more as a CMO than you made in practice, everybody want to do it. So I think even though
That's a
there's a
good point.
range, I think to answer your question, a CMO's salary is going to be fairly comparable to what a doctor in practice would make.
Okay.
Now, doctors in practice have a varying salary based on specialty and stuff, but it's a little surprising to me that oftentimes the CMO at a hospital will make comparable money to the CEO
Hmm.
for that reason, right? The CEOs, they're climbing their side of the administrative kind of corporate ladder, so to speak, but the CMOs come in at a comparable salary because they need to be attracted out of practice to do what they're doing.
Fair enough.
And then, you know, my role, since we talked earlier, is kind of a halftime, right? So I have a unique compensation structure in that I keep a time card, which initially when I took on this role, I was like, well, wait a minute, I'm beyond having to punch a clock and keep, but they're paying me for my time. Now, if I shifted over to doing a full-time CMO job, then I'd be a salaried employee. So there are many different compensation structures as you
Back when I was doing startups, there are multiple different compensation packages that you can have. One was the first startup I was a part of, I was just an owner and I had a bigger slice of the pie. And so that was high risk, high reward. And so, had the company gone off to great heights like we had thought, I would not be hosting a podcast. I would on an island in the Pacific, which it's the cold part of the Pacific and it's a huge island, but I don't own it. And the second one, I got out of that. The first one collapsed, and the second one, when I got into it, was I needed a little bit more. I needed a little less risk. I needed a little bit more money on the table. And so I did. I got an hourly rate for the work that I was doing. And that was okay. That company, fortunately, went off and took off. And it was a huge success. But I was gone from the company by the time that it did all of that, but I did work with that. I got a little bit of an hourly pay up front, and then the CEO then did get me some equity share in the company. And that was amazing and very much appreciated. And so there's a way to balance your risk and your reward. And I think everybody is very willing to get creative. And it is just a conversation. You don't need to feel bad about talking about money and about how much money you need to bring in. And some companies will just tell you, well, yeah, we're just not going to make it. We can't do that. That's okay. You don't want to be part of a company that is underpaying you and that you feel unappreciated, or that it's not worth your time. And if you are financially capable and that you're able to take on a few more stock options and get more stock options as opposed to upfront cash, hey, fantastic. And hopefully it works out for you. That's really the way that it should be. So
Yeah, I agree. We all need a salary so that we can support our family or ourselves or whatever the case may be. Um, I'm not sure that, not that you're implying that's the most important thing, because you're not, but I
right,
think it's important to remember that's not, at least for me, that's not what brings meaning and purpose to my daily work.
correct.
I needed to make a salary so I could save to put my kids through, through their education and everything. I got to go to the grocery, and you got to have money to buy food. But
Yeah,
and I think most of the time as a physician, if you apply yourself, you work hard, you take good care of your patients, we make an adequate living to get by. I don't, everybody's situation's unique, and I don't want to make it sound like everyone's going to fall into that bucket, but there are many, many different compensation models. Um, Most doctors we're not in a profession where you're going to become a multi-billionaire doing what we do. Um, it's just not how it works.
yeah. It's hard to
But
scale what we do. And
correct, because we work for ourselves, right? I mean, we don't have a lot of employees underneath us. Now,
yeah,
as CMO is a little different because you have a team, and that's part of what we're talking about at this episode. Um, but I still think you want to focus on what brings meaning and purpose to your daily life, because that's what's going to keep you from falling victim to burnout.
yep. Okay. So what has changed about your role? What has changed in your life? I know that offline we had talked about now you have a boss. So
Yes.
how is that?
Yeah, it's interesting. I mean, most of the time as a doctor, you don't have a boss. You're your own boss. And as a CMO, you will have a boss. But I've found it to be, I've learned a lot from my boss. In fact, when I was considering taking on the role that I'm in now, my wife, who we mentioned earlier, gives me a lot of sage wisdom. And she said, "Why do you want this job?" And I said, "Well, I think there's a lot to learn from the person who's my boss now and who's been my boss the entire 5 years." So it has, and that has proven to be true, which is I've learned a lot from interacting with my boss. We have quarterly meetings where we meet one on one. I get a performance review, things that are more traditional in the corporate world than you think about in the physician patient care world. But I'm I'm fortunate to have a boss that is collaborative and helps give me constructive feedback. So I have not had any problem having somebody to work with.
Well, so what about advice? Because it is very important. Again, doctors moving from being pretty autonomous and having partners, having a group practice, whatever else, to having somebody who they directly report to and having a boss. Any advice on how to choose them, or people to watch out for? Obviously you have a great boss. I know your boss, he's fantastic. And even if he's not a listener to this podcast, he's fantastic. And have you seen or heard from your colleagues red flags, things to watch out for? So if somebody is going out there for one of these bigger jobs and they've moved through the ranks of medical administration, what about them uh, selecting jobs and maybe when to walk away, if or things to watch out for, maybe even just making it more of a positive thing of what do you want to watch out for and what do you want to look for in a boss?
I think that's an interesting question. I think you want to look for someone who you feel like will be good at collaborating with you, someone that you think has good leadership skills, that you'll be able to talk to, work with, come to when you have challenging situations, which my boss is very open to that. If I have, somebody who would say, yeah, here's my number, call me when you need me. So I think those are the things that you look for. But even as a CMO, while you will have a boss, you're going to be more a member of a team. And so I would advise looking more at who you're going to be working with than who you're going to be working for. Because you're going to be working with, if you're at a hospital, as I kind of mentioned earlier, the CEO of the hospital, the CFO, the CNO, the Chief Nursing Officer. You're going to be working undoubtedly with someone who's responsible for infection prevention and quality and risk management. All of these various roles will directly impact your job as the CMO. So you want to look more at who you're working with than who you're working for.
All right. Any other things that you might have for advice for people? I know that you'd already talked about younger people who get some experience, learn how to be a doctor, get established, learn how the hospital flows, learn how the clinic flows, learn how whatever the operating room works before you start trying to get into that. And before you think that you have all the answers, make sure that you have all of the variables in the equation. What about the people who are mid-career, somebody who's like me, 13, 14 years out now, and are thinking, all right, well, maybe I do want to make a transition. Is it too late because I wasn't on the XYZ committee in the hospital? What are some suggestions that you have if people are looking?
I would say my suggestion would be find something that you enjoy, find something that you know is going to really interest you. And it's not too late. I mean, it's really never too late. Even when you're in the twilight of your career, you can still find some kind of role that you'd find where you're going to make an impact. So I certainly, if you're 14, 15 years into your career, that is the prime time, I think, to consider making a change, because now you have enough experience in all the things you talked about. But I would advise really doing a little self introspection about why you think you want to make a change, why you think you want to consider moving more into medical administration, maybe being a CMO. What's motivating you in your own heart to consider that move? And it sounds a little cliche, but you want to be running towards something, not away from something, right?
Yeah.
You want to not be leaving patients because you're sick and tired of taking care of patients. So you're going to go do something else just to get away from that.
Fair enough. That's very wise words. Matt, I want to thank you so much for taking your time and for having this really actually quite in-depth and very thoughtful conversation about what it is to be a chief medical officer, how to get there, and also how to prevent burnout. Because again, that is what this podcast is truly all about. And I really can't thank you enough for taking the time.
Oh, you're very welcome. I've really enjoyed our conversation, and I look forward to helping. If you want to have me back on again down the road, just reach out. I'd love to do it.
I would love that. So Matt is also a brewmaster. And so what's the name of the brewery now?
Yes, there are. We call ourselves Paradox. That's spelled P-A-I-R-A-D-O-C-S. Paradox.
Fantastic.
So yeah, that is one of, I spoke earlier about hobbies and how important it is. So I enjoy home brewing. It's fun to be able to give that away to people. And I brew with one of my partners.
Not available online just yet.
Not available online. Only about 4 or 5 5-gallon batches a year. Not something we're going to commercialize. But we call ourselves Paradox Brewery. Good for what ails you.
That's great. And I assume ALES or AIL. Okay, ALES. I like it. Yeah. I'm loving it. So you are not quite a microbrewer, maybe a femto brewer. So that's
maybe I'm a nano brewer.
A nano brewer? Okay, a nano brewer.
But I think, eventually one day when I do stop the medical gig, I may wind up working at a brewery. They'll probably say they can't pay me, and I'll say I'm not here to get paid.
I'm not here to get paid.
Just here to drink a beer occasionally.
Well, thank you so much, Matt. I really do appreciate your time.
Well, you're
And
welcome, Rob. I enjoyed every minute of it.
thank you for listening to another episode of the InterestingMD podcast. Please check out my content on YouTube at InterestingMD and follow me on TikTok, Blue Sky, Instagram, Threads, and Facebook at The InterestingMD and on X at InterestingMD. If you have comments or questions and want to get in touch with me or any of my guests, please DM me on socials or email me at rob@interestingmd.com. If you have any ideas for a show and you want to share your hobbies with me or don't know where to get started on your own project, you can email ideas@interestingmd.com. Please like and subscribe to the podcast and YouTube channel to get the latest content. Much appreciation to Falter Media for editing, producing, and posting all Interesting MD content. Check them out, because if they can do this for me, imagine what they can do for you. See you next week.